working and termination. So let's say I was working at a mental health facility and I'm going to be admitting this client, and we're going to be starting, because I'm going to see him every day now for a couple of weeks. These are the phases of this relationship with this client. And as with any relationship, you have some common things that kind of overlap and happen throughout it. Self-exploration, they're saying things that are making you think about yourself. You're bringing up topics with them that they have to do some self-exploration. That's the goal, is to help them do self-exploration and to learn and to grow and improve. As with any relationship, there will probably be an area where you have some misjudgments, misunderstand each other, some prejudices, some anxiety and nervousness. You're getting to know somebody new, even if it's a patient. You're a little, and they certainly are. They may be ambivalent, and when you say ambivalent, it means they really don't care. Hey, I'm going to be your nurse today. We're going to be having a relation. We're going to be working with you. Yeah. Ambivalence. That may just be they're uncertain about you and they're waiting out and watching you. So you may come across ambivalence. And they may threaten your role identity. That ambivalence may be like, well, dadgum, yeah, I'm here and I'm going to help you. So you may have some threats to your role identity. So that's why we said you need to feel real confident and self-aware and comfortable with yourself, your beliefs, and your feelings about yourself. Okay, the orientation phase. This is where we're getting to know each other. And it's crucial you establish trust and rapport. We have to get along, rapport, back and forth. We have to establish a way that we can talk to each other, and we have to trust each other. Mainly, they have to trust you. Establish a contract. Used to, when we did mental health in the hospital, we might go weeks. And so we had to, as part of our clinical, establish a contract with them. I'm going to be here every Tuesday. Can we meet at 10 o'clock every Tuesday for the next 4 weeks? Our clinical start on February the 3rd, and our last one will be March 3rd, and that's a contract with them. They agree to come meet me at 10, and that's really what happened. We'd go to this big, huge day room at this big, huge hospital, and you'd sit and wait to see if they'd really come down and meet you. Half the time they were waiting to see if we were really there like we said we were, and once they knew that we were there, they could trust us, and they'd come meet us. You're in this beginning orientation phase. You're going to be doing your assessment. Come up with your nursing diagnosis for this client. Maybe it's anxiety, and so you're going to let them know some goals that you think would help them with their anxiety. So during our meeting, we're going to do this, and I think it would be beneficial if we worked on this and this with you, and they have to agree to it, and then develop a plan. Well, how are we going to do this? And then we talk about how we feel about stuff. Mainly they talk, and we listen. They'll test us. They'll test you. Patients will test you, especially mental illness. You need to be able to be the one that sets the limits. Kind of back to the patient that we said that might have put their hand on you inappropriately. You have to set the limit. Still shows concern if the client acts out. You can't just ignore bad behavior or not assess things or ignore it. You're still a nurse-patient relationship. You have to show concern for what's going on. And like we said, still be there if the client is late. I remember them drilling that in her head. Don't just go and see if they're there and get up and leave. They may be watching to see if you're really coming. So sit and wait until they get there, even if they're late. So those are some of the things nurses do, you would do for this testing behavior. Then, so you've met each other, you've done your assessment, you got your nursing diagnosis, you've come up with some goals, you're establishing trust. Now we move into this working phase. This is where anything therapeutic that's going to help this patient, most of it happens now. You want to promote the client's insight. Well, how do you feel about that? Well, how do you feel when this happens? What do you think would be a better way to approach this? What would you do the next time this happened? You're helping them explore their feelings. It's kind of like in the sim lab when we do debriefing. If we brought you guys into sim lab after that 20 minutes and just said, okay, so next time you're in sim lab, you need to do this. And I noticed you didn't take the blood pressure and get a good set of vital signs. Would that be as helpful to y'all as if we sit there and kind of say, well, how'd you think it goes? How'd you think it went? We're helping you dig down and get some insight into that clinical experience instead of us just telling you. Because, and that's what you want to do in this work and relationship. I can sit there and tell them all day long how they can fix their anxiety problem. But what you want them to do is develop insight, because they know some things you don't know and you want them to solve it. You can teach them coping mechanisms. Well, why don't you try doing this the next time that happens? And then they're going to go off after the meeting and maybe try some of the interventions and the plans you have. Next meeting, during the working phase, you're going to evaluate, well, how did that work? So it's the doing, the evaluating. The working phase. You need to know these different phases of a therapeutic relationship. During the working phase, you got some jobs you got to do. You got to maintain this relationship. You got to keep digging and get more information. You got to keep helping them try to learn new skills and new behaviors to help them improve their mental health. You're trying to facilitate a change. When we so I'm not trying to force you to change. I'm trying to facilitate a way for you to change. It's like me in here teaching y'all today. I can't learn it for you. I can stand up here for 6 hours, but I can't learn it for you. But I can facilitate a path for you to go home and study and learn it. Same way with the working relationship with the client. Give them some skills and also that they can change. Termination. In that working phase, that's where some of you may get conflict in there. You can't work with somebody for an extended period of time and not have some conflict and all. And there may be some not agreeing on goals and all, but that's when you work it through. That's why it's called the working phase. Work through that. If there is some conflict or some heated emotions or something, it's an opportunity to dig down and figure out why. Work through it. Just remember, working phase. Termination, that's where you evaluate the outcomes, just like with your nursing process. You evaluate the outcomes, make sure you got your plans for the future, what they're going to do. You get to talk about your feelings. Sometimes patients really don't want that relationship to be over, so they may regress just to try to keep things going. But you as the nurse have to end, it has to have an end with this therapeutic relationship. It just can't drag on. And so you have to end it, work through those feelings, give them an opportunity to talk and all. Kind of summarize, wrap up what they've learned. Help them feel good about what they've done and move on. Verbalize that they're a little sad it's ending, but that it's moving them on to a new step. Well, why do you end the relationship? Why can't you just keep on and on? Why would a nurse-client relation end? Well, their symptoms may be better. They're doing better socially. They feel better about themselves, have a better sense of identity. You have met their goals. Or because you've just reached a point where nothing's getting done. We're just at an impasse. This ain't working. You're not changing. We can't get past it. We can't reevaluate and come up with new goals, so we're just going to end it. Because of resistance, they don't want to do what you need them to do, or some counter-transference where I'm putting my feelings onto them, and it's just turning into not a therapeutic relationship, and that's when you need to end it. And they need to maybe get another nurse. Okay, interactions with select behaviors. Communication when you have these certain behaviors. What do we do? Okay, violent behavior. I think next to worrying about saying the wrong thing in the mental health clinical, the next thing you're worried about is violent behaviors. So if you have violent behavior, the patient that is pacing the floor, clenched fist, usually talks and all, but is very withdrawn and very agitated, and when you talk to them, they're just on edge. They're at risk for being violent. Do I go to that person and go, hey? No, don't you. Touching, avoid it at this point, okay? Give them plenty of personal space. If I do want to talk to you, I don't come and get up, all in your space. And you need to leave or call for assistance. And you always keep yourself between you and the door. Okay, you don't let them get between you and the door. So be wary of your surrounding. Call for some help. Give them their space. Hallucinations, delusions. Arguing is ineffective, like my grandpa. I just don't see them kids. Well, for a 10. And you can, my aunt did try doing it. She presented reality in a logical way. Well, I'm sorry, I just don't see those kids. But you're not going to argue. No, there's no kids there. Now, don't start that again. Don't argue. There ain't no kids there. Stop that. Or you have two clients that are confused and they're both confused and they're getting each other confused in the hall. The best way is just to separate them and move along, but don't argue. Don't escalate it. Are you seeing them kids again? Are you really? I don't think them kids are there. Really? You don't want to start, provoking. Conflicting values. Assist the client. Let's see. Examine outcomes of beliefs on lives, relationships. You're not going to change their values, but you can help them to clarify their values. And if it's destructive or something, you could help them work through some destructive values instead of just saying, we got to change the way you think. You could say, how come you think this is that way? How come you put value in that? Let's talk about it. But you're not going to be like, all right, I'm going to change you. And then manipulation, probably the biggest issue in a nursing unit, manipulation by a client with mental illness. Avoid a power struggle. You're not going to get into a tug of war with the patient and win. You probably need to get at the root of why they're trying to manipulate you. And then remember when we talked about boundaries, that you're the one that has to set the boundary. No, I'm not going to let you sit down here in the day room past the time when you're supposed to not be in here because this unit rules. I'm not going to argue with you, but these are the rules and you have to follow them. Don't start negotiating with them. Please let me sit in the day room and watch TV till 10 o'clock and it's against the rules. Well, I'll let you do it this one time if you just promise later. You just got manipulated. You win. You set those boundaries. You don't argue, but you're the one setting the boundaries and you're in control. And then when it says help the patient express needs directly, now you can't stay down there until 10 o'clock. What, is there something else bothering you? What else? Are you feeling like you need to, what do you need to talk about? Because they may just be, they're in a hospital, they're being told what to do, when to eat, when to go to the rest, when to take their meds and all. They may just need to express some feelings. But that's a better way to approach it than just getting into a power struggle. If you're in a situation and a client, that's the other thing too, about back to violent behavior or disruptive behavior. Same with crying. Allow them some privacy. If someone is upset, they're really having a hard time, you're just not going to leave them in that milieu setting in an embarrassing. Let's go back to your room and I'll help you let you take a few minutes to get a handle on things. Same with violent disruptive behavior in that day room or something. Let's say we talked about giving them space and all. But if you've got a violent, disruptive client, you're going to get them out of that group setting. Here, why don't you walk down the hall with me? Or let's go back to your room. But try to get them away from the other people. The sexual innuendos, inappropriate touch, we've already talked about that. Or if you happen to walk in on some sort of a client by themselves doing something of a sexual nature, you can just say, I'll leave, I'll be back in a few minutes. But you don't want to just take the opportunity to embarrass somebody. If they're suspicious of you, that you can tell they don't trust you and you're working on communication, just always remember to be simple, clear, and congruent. If I told you earlier that the time to be out of the day room is 8, I'm using simple things, but if I told you it was 8 o'clock earlier, then when I talk to you again, I'm going to tell you it's 8 o'clock again. I'm going to be real simple and real clear. Because you'll have a lot of clients that are very suspicious. Always remember you can communicate verbally and non-verbally. Remember, about 80% probably is non-verbal. So you've gone over this before, so I won't go over it a lot. And we've talked about it. Eye contact, ideal time to look at somebody eye to eye is about 2 to 3 seconds. After 2 to 3 seconds, and I'm still looking at you eye to eye, it starts to become very uncomfortable. And that was probably about 4. So just, remember that little benchmark. But you need eye-to-eye contact, but not a ton of it. Absence of it will make that suspicious patient even that much more suspicious. And always keep in mind cultural significance. Some cultures think it's disrespectful for you to make eye contact. So you may want to investigate that further if you think there may be some cultural issues. Your gestures can mean several things, so just watch your hands, watch where you put your hands, watch crossing your arms. This is just like the biggest, that has such an inference of stop or don't come closer, or I've got it, point your finger, watch that. Sometimes when I'm talking, I'll point, and then I forget that I'm not pointing at the board anymore and I'm talking to you. So watch your gestures, finger pointing and things like that. And when in doubt, you can always just drop your hands down. If you're nervous and you find yourself doing something, or just drop your hands. And that still has an open posture, but is not intimidating. Again, we've talked about touch already, so I don't need to go over it, but do review it when you get home. You don't want to be without touch. So I just encourage you to always remember it is okay to touch people and use therapeutic touch. You just have to be smart about it and follow your guidelines and your assessment skills. Okay, when you're talking to a patient in a mental health setting, it is goal-directed. You're not just babbling to be talking. You're focusing on trying to help them. Most of what you do in mental health is give meds and talk and therapeutic communication. Okay, you're not doing bullies, you're not doing all that kind of stuff. You want to actively listen, remember, hear what they're saying. Frequently ask open-ended questions, and when you're trying to think of an open-ended question, that is the hardest thing to do in the world, because the only thing you can come up with is a yes-no question. So have your little wheelhouse. And in your skills module is some good examples of all of this. So when you're studying, look at your skills module. We can look at it some more tomorrow too. And we've talked about this already. Stop talking, listen to what they're saying. Pay attention to their tone of voice and their inflection. Wait for them to finish. And don't be turned off by some of the stuff they're saying. Still keep listening, watch their body language, and listen to what they're saying. More about active listening. Don't, we had a patient one time with a student, and I kept saying, are you ready to go in and do your assessment with them? No, they're just not wanting the nurse to do anything right now. And I even poked my head in a couple of times, and I was like, wow, what's going on with this client? She just really doesn't want to talk. But, you know, you got to go in and do the assessment. And so when it says here, don't make your judgments ahead of time, I don't. I mean, I got to do the assessment. I'm just seeing what I see. I really haven't formed an opinion. But as we started to talk to that person, just this horrible life story poured out, and it was med-surg. It wasn't mental illness. It wasn't a mental health unit. But this woman's story had so many sad things that had just happened to her within a week or two. It was just like, wow. And we just kept listening. Well, hey, I know you don't want us in here, but, it's almost noon. We've got to do this assessment, and we'll help you do some other stuff. Well, all right. Don't form your opinion right then. Because I would have been like, well, he didn't want to talk. We're not going to talk. That's not my job to form that opinion ahead. Mine is keep assessing. How are you doing today? Did you get up? Is pain better than it was yesterday as we're changing his bed and all that? Yeah, it's a little better than it was. When are you planning on going home? You always, work on that discharge plan. Well, I don't know. And then it led to, well, I lost my home. Well, when I had a car wreck out of state, and I've been here 6 weeks, I was, and so then it just led to, and before it ended, it was just the best interaction that I think we've had, and even the student was like, it was awesome. So we didn't form our judgments. We just keep talking, keep listening, keep doing your job, and see what you find out. If you don't understand what they're saying, you can always say, well, I'm not sure I understand what you say. Could you please clarify? Open-ended questions just can't be answered with yes or no. Tell me more about how you feel. How does that make you feel? Not, does that make you feel bad? Does it make you feel bad? Yes. And you're like, okay, there we are. Does it make you feel bad? Nope. Okay. Then you're at the end, see? So when you ask, well, how does that make you feel? Then they have to do first some self-reflection. How does it make it? And then they talk. Okay, so practice looking through the at open-ended questions, and there are some really good examples right there. Open-ended ones usually end up with how. Tell me. What has been more difficult? Those are some good ways to start those open-ended questions. Tell me more. How. Now, after they've said something to you, here's some more techniques you'll want to use in therapeutic communication. Restating. Okay, so you said when you lost your job, that just made you feel like you didn't have a reason for living. That's restating. And kind of pretty much parroting what they said. If he said, I just don't have a reason for living, then I would parrot it back. So you said losing your job made you feel like you didn't have a reason for living. It's restating. Paraphrasing. So when you lost your job, that was pretty hard on you, and you didn't feel like you could go on. I paraphrased. I changed what they said and kind of put my spin on it. Clarifying. Okay, so let me make sure I heard you right. That was so bad when you lost your job, you felt like you didn't want to live anymore, right? And you're asking them to clarify. And then summarizing. Okay, so you said you had this job, you lost it 6 months ago, and after that you kind of lost part of your identity and you didn't want to live anymore. Summary? Yeah. So those are techniques you can use as they're talking to keep the conversation on track and therapeutic for them. You want to avoid using why questions, because even you feel that way. Well, why'd you do that? That's just the way that comes across. Well, why'd you do that? So kind of try to avoid whys. Avoid false reassurance. We already said that. Oh, it'll be fine. Most people who have this, they do great. Yeah, you'll be fine. Avoid that unless that you know for sure it's going to be great, which most of the time we don't know that, so avoid that. Giving unwanted advice. One time I had that happen to me, And I found that if I just did this, got out and did a few things, I felt don't give unwanted advice. Use an authority. Look, I'm the nurse, and I'm telling you, you're going to do this. Avoid that. Using professional jargon. Well, I think if we just go ahead and switch your, Lexapro to BID, and then we go ahead and start throwing a bunch of stuff in, don't use the jargon. Using leading or biased questions. Well, I would never do that, but you said you did. Why would you do that? I've already let them know that whatever they're going to tell me, I don't like. So avoid leading them on. You would never do that, would you? It's a leading question. Talking too much. Give them time to talk and interrupting. Let them finish what they're saying, just unless it's something where you really need to. Now, ways that you can, we've already said these. Empathy, mutuality, confidentiality, those promote communication. We've already gone over this. People that are hearing impaired, use your normal tone of voice, don't shout, talk towards their good ear. Okay. We will end on that. Long day. Please look in your skills module tonight, go over and read your stuff. Look in your skills module. It talks a lot about therapeutic communication. That's a big portion of this unit. How would you respond to a